So good morning everyone. We'll start with the session. The first presenter is Dr. Sharanya. Thank you. Yeah.
Good morning, everyone. This is a case series about the fundus and optical coherence tomography findings in a series of patients with retinal astrocytoma. So, retinal astrocytomas, they are actually hematomas, which are benign glial proliferation of tumors which arise from the retinal nerve fiber layer. So, they can be isolated or most commonly associated with tuberous sclerosis. The other associations which have been documented are neurofibromatosis, retinitis pigmentosa, Usher's syndrome, Stargardt's disease, and gyrate atrophy. So it's one of the major criteria in the tuberous sclerosis complex diagnosis, and it's the most common ophthalmic manifestation, which is seen in 50% of the patients, and 30% of these are bilateral. So it's classified based on ophthalmoscopic features and OCT features. According to the morphological classification, there is type 1, 2, and 3, whereas type 1 is a well-circumscribed translucent gray-white lesion. Type 2 has calcification, also called mulberry type, and type 3 is also called mushroom type, which is a transitional lesion. According to the OCT findings, it's divided into 4 types. Type 1 is a hyperreflective thickening of the retinal nerve fiber layer. Type 2 is a dome-shaped elevated lesion with retinal disorganization and abrupt transition between the tumor and the normal retinal surface. Type 3 is also dome-shaped, but it has a moth-eaten appearance due to intralesional cavitation. And type 4 is an optically empty lesion. So the first case was a 31-year-old female who was diagnosed with tuberous sclerosis complex. She had no ocular findings, but she had systemic and imaging features consistent with tuberous sclerosis complex. So the fundus of the right eye showed a smooth, non-calcified, grey-white translucent lesion, and the left eye there was a mulberry-like lesion with glistening yellowish spherules of calcification. OCT of the right eye showed hyperreflective thickening of the retinal nerve fiber layer. So this is suggestive of a type 1 type of lesion in the right eye and a type 2 in the left eye. The second case was a 14-year-old female who was diagnosed as tuberous sclerosis. Fundus lesion of the right eye showed smooth, non-calcified gray-white lesion in both the eyes, and OCT showed homogeneous hyperreflective dome-shaped thickening. The third case, which was 20-year-old male, also with tuberous sclerosis, he had a unilateral lesion, which was a well-circumscribed opaque lesion, this is a transitional type 3 lesion. The OCT showed a significantly elevated lesion with intralesional cavitation with posterior shadowing. The fourth case was a 37-year-old female who also had tuberous sclerosis and a unilateral presentation. There was a smooth, non-calcified gray-white lesion, and the OCT was limited by the site of the lesion. The fifth patient was a 16-year-old male who also was diagnosed as tuberous sclerosis complex. He had well-circumscribed, smooth, non-calcified lesions in both the eyes, and the OCT showed the fourth type of lesion, which is an optically empty lesion with hyperreflective thickening anterior to the lesion. So all patients with tuberous sclerosis complex should ideally have a complete ophthalmic examination and a OCT for classification. So the lesions which are classified as type 2, they are commonly associated with cutaneous fibrous plaques. Those which are classified as type 3 are associated with subependymal hematomas, and type 4 is associated with pulmonary lymphangiomatosis. So each type has a systemic association. So spectral domain OCT can be used to facilitate the detection and the follow-up of retinal astrocytic hematomas.
So what are the common problems with retinal astrocytoma?
Most of the cases are benign and they do not increase in size, but the lesions which are either juxtapapillary or have a macular location, they tend to have progression and show aggressive behavior such as retinal traction, schisis cavities, accumulation of subretinal fluid, and exudative retinal detachment, and cystoid macular edema.
Was there any miss in your diagnosis clinically and OCT wise?
Yes. In a few cases, the morphological classification and the ST-OCT classification did not correlate.
Okay.
Thank
Next, next one. Dr. Raka Chatterjee, no?
Yeah.
Raka Chatterjee.
Yes.
Yeah, please present. 25 में से देने हैं.
Good morning, everybody. I shall be presenting on orbital lymphoma, a clinico-pathological correlation. That lymphoma is a diverse group of malignancy with different histopathological subtypes and clinical presentation that vary with the geographical location. The aims of the study were to know the clinico-pathological correlation of the cases of primary orbital lymphomas, the different histological pattern, and the various modalities of treatment and the ultimate treatment outcome. It was a retrospective observational case series where 48 eyes were taken in a span of 7 years, and all cases were having primary orbital involvement, and patients with a follow-up of less than 6 months and previously treated patients were excluded from the study. Thorough clinical examination with appropriate orbital imaging followed by incision and excision biopsies were done. Histopathology and immunohistochemistry were done to confirm. Staging workups were done with the help of hemato-oncologist, and on SOS basis he did the other required tests like whole body PET scan, bone marrow biopsy, etc. And we had referred the cases to oncologists for further management. 48 eyes were there. 32 cases were unilateral and 8 cases bilateral. Age range were 55 to 70 years, and male preponderance was seen. Most common sign was proptosis, and the ratio between the well-defined lesion and the ill-defined lesion radiologically was 4:44. That means most of the cases were ill-defined. And extranodal marginal zone lymphoma versus non-extranodal marginal zone lymphoma, the ratio was 31:17. That means EMZL type was common. None of the cases were of T-cell origin, and 25% cases died in a 5-year follow-up. And these are the different treatments which we opted for: the surgery only, the radiotherapy only, radiotherapy plus chemotherapy, chemotherapy only, surgery plus radiotherapy. And the tumors, orbital lymphomas, all were actually E according to the Ann Arbor staging, the extranodal type, and it was categorized accordingly. And the treatment outcome were seen, and the 25 cases, they were complete remission. 4 cases showed partial remission, 4 stable disease, and in 12 cases there was death due to lymphoma or some other cause. And I'd like to highlight some of the cases, and in this case a middle-aged man presented with inferomedial orbital swelling. On imaging there was a mass noted in the infromedial orbit, which was iso-intense in T1 and T2 weighted images, and excision, complete excision was possible, and histology suggested of lymphoma, and the immunohistochemistry was suggestive of expressed CD20 positivity, and it was a EMZL type of MOLT type of lymphoma. This was a case where bilateral proptosis and imaging showed a homogeneous soft tissue density enhancing mass at both of the eyes. Incision biopsy were taken, and lymphoma panel investigations suggested it to be of extranodal marginal zone lymphoma. This was a case little unusual. The lady presented with the features of orbital cellulitis, but on imaging there was a homogeneous lesion, almost encapsulated, but during and planned excision biopsy, it was not possible to take it out in toto. So ultimately, an incision biopsy was done, but the histopathology, it was a diffuse large B-cell lymphoma. So the most common histology was extramarginal zone lymphoma, non-EMCL, that means diffuse large B-cell lymphoma, follicular lymphoma, small lymphocytic lymphoma, mantle cell lymphoma, or it can be of T-cell lymphoma. Immunohistochemistry confirms the diagnosis. Incidence of NHL increases with age. Now MALT, or mucosal associated lymphoid tissue, follicular lymphoma, small lymphocytic lymphoma, and earlier staging had a favorable prognosis. Poor prognostic factors included a high-grade histological subtypes and advanced staging. But the main limitation of my study was it had a relatively small sample size. Now, what this study confirmed and added, the study was performed in Eastern India. Our study did not detect any T-cell lymphoma, and EMZL was the most common histology. The mucosal associated lymphoid tumor, follicular lymphoma, and small lymphocytic lymphoma, and the earlier staging had the better prognosis. Thank you.
What are different treatment modalities in your case series? Are you, of course, that is not part of your study, but how you treated your cases?
I had done, after confirmation of the diagnosis, sir, I had sent the patient to the oncologist. Now, oncologist had, apart from the surgical part, few cases the radiotherapy was done, and this is the most common thing. Because of this low-grade MULT type, EMZL type, the radiotherapy, 35 to 45 grays, it was done. And some aggressive variant like a DLBCL, apart from the surgery, the chemotherapy was given. So the treatment modality is radiotherapy only, radiotherapy plus chemotherapy, chemotherapy only, apart from the surgeries were done. And only few very rare cases complete in toto excision was possible, which I showed in the first case. But after that, I had sent the patient to oncologist and whole body PET scan was done. No hotspots were found. So I am keeping the patient under follow-up.
How do you compare this with your Western literature? Which usually we have Western literature. This is the study done from India.
Yes, sir.
You have seen that T cell is not found.
No.
What are the other impressions from,
Sir, T cell is not found in my study. In Western literature,
any other striking feature you have found in this study? Because this is done in India or,
yes,
in
sir.
Asian population.
Yes, and the age group in Western literature, in our case, it is more advanced age group. In Western literature, it comes from much earlier age.
Any other finding you have got?
Though
Histopathology same consistently, whatever you have got.
The most common here was extramarginal zone lymphomas. In Western also extramarginal zone lymphomas. I have not seen.
Okay.
Thank you.
Okay, thank you.
Sir, I have another session to attend.
No problem. Next speaker, Meghna Roy. Meghna Roy is not there. Okay. Huh? You are Meghna Roy? Yes. Okay, then we can have the another presenter. You can clear your things. Next is the
Third speaker.
Okay.
Senton.
Good morning, everyone. I would like to present before you the outcomes of combined ruthenium plaque brachytherapy with transpupillary thermotherapy in thick choroidal melanoma. So uveal melanoma is a common primary malignancy in adults. It is life and sight-threatening if not treated at the time. The treatment modality is mainly determined by the size and location of the tumor. Since the advent of brachytherapy, there has been a change in the line of treatment of melanomas depending upon the size. So brachytherapy mainly delivers curative dose to the tumor while it protects the surrounding normal ocular structures. Whereas in transpupillary thermotherapy, which can penetrate up to 4 mm depth, it causes necrosis, thus destroying the tumor. The rationale of our study was that we treat the tumor from behind by keeping a episcleral plaque, ruthenium-106, along with treating the tumor anteriorly by transpupillary thermotherapy. So the ruthenium produces beta radiations when compared to iodine-125 plaques, which normally produces gamma radiation. Since beta radiations are not that much penetrating like gamma radiation, the untoward complications or untoward radiation to the surrounding structures were minimized. But the major concern was that because it has a steep dose gradient, steep dose fall rate, the apex may not receive adequate treatment if the tumor is more than 7 mm. So we assessed primarily the outcome of the combined treatment and secondarily the other parameters like ocular surface, hysteresis of the cornea, visual acuity, IOP, etc.
The study period was 1.5 years. It was a prospective interventional study. The tumor thickness we considered were apical thickness ranging from 5 mm to 8 mm and largest basal diameter not exceeding 16 mm. A convenient sample size of 10 patients were recruited. So initial pre and post-operative assessment were given. The patients were confirmed with ultrasound assessment of the tumor and clinical examination. After getting proper consent, the radiation dose was calculated by the radiation oncologist. TTT followed by plaque brachytherapy was given in the same sitting. After removal of the plaque, 3 cycles of TTT were given in the consecutive month. At every 6 months and 12 months, metastatic assessment was given. So there was a statistically significant decrease in the apical thickness at 3 months, 6 months and 12 months. The percentage reduction at 12 months was 72.31% among tumors with apical thickness of 5 mm to 6 mm, whereas in tumors with apical thickness of 7.1 to 8 mm, the decrease in the apical thickness was 17.81%. So figure 1 shows a pre-op ultrasound showing the tumor, whereas post-treatment the figure 2 shows no visible tumor. Figure 3 shows a pseudocular image where we can see the tumor marked by the black arrow, whereas in figure 4 there is a flat scar with associated radiation retinopathy. The mean scleral dose was 518 gray. The mean tumor apical dose was 78.5 gray. At 1 year, the mean apical thickness reduced to 3.4 mm. Tumor control and globe salvage rates were 100% at 1 year. At 1 year, 1 patient developed distant metastasis, which was diagnosed in PET CT scan. It was in liver and vertebra. The patient was referred to oncology department later. And 3 patients developed radiation retinopathy. So we believe in tumors with 5 mm to 8 mm apical thickness and LBD less than 16 mm, the combined ruthenium plaque brachytherapy plus TTT can be used effectively, and higher response were seen in tumors with apical thickness of 5 mm to 6 mm. Thank you. Yes, ma'am.
Setting of the TTT that you used for your patients?
Yes, ma'am. We used a 810 diode laser, and the spot size was 3.4 to 4 mm, depending upon the location. And the setting was about 400 milliwatt, and the exposure time was around 1 minute. In case if the tumor was not responding, we increase the power by 50 milliwatt of increment till we get a grayish white discoloration.
And what was the maximum time you were using on maximum number of spots per session of TTT?
It was like maximum number of spots.
Yeah.
Ma'am, it was around like 10 to 12 spots per second.
Okay, and what was like TTT, how many sessions were required for this 10 patients that you showed?
Ma'am, initially we gave before the placement of plaque. Then after removal, in first, second and third month, we gave a TTT. So in 2 patients, after second TTT, in tumors which were around 5 mm, they were completely a flat scar. In the tumors more than 6 mm, we had to give a third TTT also. But till now, after the study period, we are following up the patient. After the third dose of TTT, none of the tumors have progressed in size. Everything is stable. So we are keeping the patients under follow-up. In case the patient, we do not feel like it has not reduced like we have planned, then we give an additional TTT depending upon the progress of the tumor. But that was out of the study period, so I have not included it in this.
Okay, thank you.
Thank you.
Next speaker is Parth. Dr. Meghna, I think she is not ready with her presentation. So we can call next speaker, Dr. Parth.
Yes.
Yeah, please continue.
The first one, sir.
Good morning to all the esteemed delegates and chairpersons present here. I'm Dr. Paj Mehta from Shankar Netralaya, and I'll be speaking on histopathology, immunohistochemistry and molecular biology in enucleated eyes in ocular inflammation. The aim of this study was to report the histopathology, immunohistochemistry and molecular biology in enucleated eyes secondary to ocular inflammation. This was a study conducted over a period of 10 years where a retrospective chart analysis was done for 13 enucleated globes secondary to intractable ocular inflammation. Sympathetic ophthalmitis accounted for 6 eyes. Tuberculosis was the etiology in 2 cases of Eales disease, 2 cases of panuveitis, and a case of sclerouveitis. We also studied a case of acute retinal necrosis and VKH disease each. Acute retinal necrosis it shows a histopathology of enucleated globe in a 40-year-old immunocompetent man, showing chronic inflammation of the peripheral retina with perivascular lymphocytic infiltration. The right side shows a microphotograph showing retinal vascular occlusion. Viral inclusion bodies were seen in the necrotic retina. Semi-nested polymerase chain reaction for detection of varicella virus showing the targeting ORF63 region. The specimen for paraffin blocks were subjected to the semi-nested PCR, which was also positive for the ORF63 region. Immunohistochemistry was strongly positive for CD3 T cells. Sympathetic ophthalmitis is characterized by diffuse granulomatous uveal involvement. There is a relative lack of retinal and choriocapillaris inflammation. Dahlen-Fuchs nodules may be seen, and the granulomatous process may even extend to the scleral canals and the optic disc. Histopathology slides showing ciliary body inflammation, diffuse inflammation in the choroid. Diffuse inflammation of the choroid with choriocapillaris uninvolved, and special finding of phacoanaphylaxis was noted in one of the cases. In the isolated case of Koyanagi-Harada disease, we found diffuse choroidal inflammation with lymphocytes and plasma cells. There is photoreceptor degeneration with pockets of exudation seen in the outer retinal layers. Choroidal neovascular membrane was seen with outpouring of the RBCs. Immunohistochemistry showed strong CD3 and CD20 positivity. In one of the cases of Eales disease, neovascularization was seen into the vitreous cavity with lymphocytes in the inner vascular and perivascular areas. Generally, granulomatous response secondary to mycobacterial TB shows type 4 hypersensitivity with CD4 T cells, but there was a characteristic CD8 cytotoxic T cell positivity in case, possibly because of ocular immune privilege. Nested PCR was positive for MPB64 and IS6110 genome of Mycobacterium tuberculosis. This is a gross specimen showing a thickened choroid in a case of tubercular sclerouveitis in a patient with rheumatoid arthritis. In another patient, multiple granulomas were seen in sclera, and acid-fast bacilli were isolated within the retinal pigment epithelium. Agarose gel electrophoretograph was positive for both the mycobacterial tuberculosis genomes. To conclude, histopathology, immunohistochemistry, and molecular analysis of enucleated globes can give an insight to etiopathogenesis of intraocular inflammation. Thank you.
Yes, compared to immunohistochemistry and histopathology,
Yes, sir.
what is the difference?
Sir, histopathology is basically the tissue that you take and with serial staining of different stains that we use, we can pick up particular stains of tissues. Immunohistochemistry basically involves usage of markers, antibodies, which specifically bind to the antigens, and those can be detected with respect to serial testing, specific tissue targeted antibodies.
Clinically, how you judge that this specimen you want to do immunohistochemistry or you want to do only histopathology?
Sir, it was done for all of the enucleated eyes which are having ocular inflammation, intractable ocular inflammation which had no perception of light and no visual prognosis. Many patients wanted a cosmetic correction also. So for that, enucleation was done with ball implant.
Is there a protocol to do in all cases of inflammation? So you have enucleated the eye.
Sir, the whole purpose was to basically know the etiopathogenesis. So whatever causative factors we could find out from those eyes, those were studied, and a particular pathology or etiopathogenesis responsible, we tried to find that out. Thank you.
Next presenter, Samiksha. Dr. Samiksha is not there. Okay. Dr. Meghna is ready. Huh? Preview room में गए. Okay. Then Dr. Mohit. Dr. Mohit Dogra. Dr. Rolika Bansal. Yeah, please. काय करणार आपण? 2-3 लोकांनी.
May I begin, sir? May I begin? Good morning, everyone. So I'll be talking about orbital cavernous venous malformation, and this is one of the large case series that we have done. So orbital cavernous venous malformation happens to be a benign primary orbital tumor, specifically occurring in adults. And it happens to be the third most common diagnosis after the lymphoid tumors and orbital inflammatory syndromes. It has mostly asymptomatic until adulthood, when it is diagnosed with various clinical symptoms. It is usually solitary, unilateral, and rarely associated with other vascular anomalies also. So we conducted a retrospective interventional study where 80 patients were analyzed, and they were all radiologically confirmed, and loss to follow-up were excluded. We saw that OCVM constituted to be 5.4% of all the operated orbital tumors in the study period, and the age range varied from 3 years to a 65-year-old. So that's not just in adulthood, it happens in young age too. We saw a myriad of clinical presentations, proptosis being the commonest, diminished vision, palpable mass. Disc edema was also present in certain cases along with choroidal folds. Strabismus and ptosis were also common findings. Radiologically, on CT scan, we saw that the tumor was well circumscribed, hyperdense, with bony remodeling due to the chronicity, with mild contrast enhancement. MRI showed a heterogeneous mass, hypointense, and hyperintense. What's most important was the flow void. That is the diagnostic. The variable presentations were the mass was intraconal in 66%, that was commonest, but we also saw extraconal extension, extraconal mass overall, diffuse presentation, a very rare involvement of the muscle and the optic nerve too. So we had multiple interventions, that is ranging from lateral orbitotomy, anterior orbitotomy, and transconjunctival orbitotomy. Here is a video showing the lateral orbitotomy, wherein after the subauricularis dissection, periosteum is reached and it is elevated. After elevating the periosteum, sometimes we have to go ahead with the bone cut. Here, a bone cut was performed for good visualization of the tumor, and cryo-assisted extraction of the tumor was performed. Similarly, cosmetically, we had to take care of the cosmetic aspects of the patients, and we did transconjunctival approach, where the inferior fornix is approached, and after periosteal incision and dissection, again, it was visualized well, and cryo-assisted tumor delivery was performed. So transient complications were seen, that is ptosis in few cases, ocular motility restriction, visual loss, and diplopia. However, at a mean follow-up of 12 years, all the patients were functionally absolutely normal. So these are the few cases where we followed the transconjunctival approach for keeping the cosmetic part in mind. And we had complete cosmetic outcome in all our patients. So in conclusion, I would say that we know that it's a benign vascular tumor. It is seen in the middle age group, but we saw a correlation of 3 years to 65 years. And it presents mostly as proptosis, as 75% of our cases, and a well-circumscribed intraconal mass must not be missed. And radiological confirmation is mandatory because the differential diagnoses are many. And meticulous planning of surgery, especially by transconjunctival inferior fornicial approach, which we did in 22.5% cases, it leads to minimal complications and gratifying outcome, as 100% cosmesis was reached in our patients. Thank you. These are my references.
That was a good presentation, Dr. Rolika. How many cases did you study?
Ma'am, 80 patients.
80 patients.
Yes.
And follow-up was still?
12.5 years was the mean, plus minus 1.8.
Yeah. What was the differential diagnosis that you looked into?
Ma'am, the differential diagnosis ranged from vascular tumors to even fibrous tumors. We had solitary fibrous tumors and benign fibroblastic hyperplasia. We had cavernous malformations, even the vascular malformations. So it was very important for us to do an MRI and take the radiologist's opinion. So our opinions are mostly taken by neuroradiologist who confirms the flow void. So the flow void is the indication which clarifies and confirms it.
What was the size of the largest tumor?
the size of the largest tumor. So we have not really kept the size in mind because radiologically when we do the sections, so it is possible that the maximum dimension might vary.
Okay.
I have not assessed the size, sir, here.
Okay. And any patient required another surgery for cosmetic purpose or only
Yes,
one
sir.
surgery?
So the ptosis patients, there were 8 patients who developed ptosis because the LPS is also sometimes manipulated in the process because the fibers of LPS are often attached to the tumor. So they had to undergo the ptosis correction surgeries. That were 8 cases.
Hi Rolika, great presentation. So I was curious to know that 3 approaches were used for these tumors:
Yes.
transconjunctival, anterior orbitotomy, and lateral orbitotomy. So how was the complication profile different between these 3 approaches? I saw one patient you mentioned to have total vision loss post-surgery.
Right.
What was the approach for that particular patient?
Yes, ma'am. Ma'am, the patient who had total vision loss was the one with the optic nerve involvement of the tumor. So it was already known to the patient beforehand only that since it was a like posterior presentation, the tumor was present posteriorly and attached to the optic nerve. That is where the vision loss occurred. The variable presentations that were there were based on the site of the tumor. The ones which were more approachable, they were taken out by anterior approach, but we had to go for a deep cut and a bone cut in lateral orbitotomy for the ones which were posterior. Inferior approach was used for the ones which were in the inferior quadrant, and therefore we could get good cosmesis in those cases.
Yeah, so how was the complication profile different?
Complication profile, ma'am, mostly in the lateral orbitotomy patients, wherein the, like as I mentioned that the LPS was attached, there we got the ptosis for sure, because the LPS fibers were attached diffusely. So when we are manipulating and dissecting it off, we saw ptosis patients there. The ones with the visual outcome, as I explained. Diplopia was seen in one case where it was an anterior orbitotomy, but the patient had medial rectus involvement. That is where the diplopia occurred. So it was not based on the surgical process, approach, but it was more on the site and the involvement of the adjacent structures.
Okay, thank you, Rolika.
Good morning, everyone. The topic of my presentation is extensive periocular basal cell carcinoma, review of 22 cases. As we all know that more common in Western country and 86 to 90%, and it is less common in Asians. It is the most common cancer in the world, and 80% of BCCs occur in the head and neck region, of which 20% occur on the eyelids and periocular area. BCC constitutes 90% of malignant eyelid tumors with a slight male preponderance. 5-year cure rate is 94 to 99%. The aim of my study was to observe the clinical profile, histopathological pattern, management outcome of extensive periocular basal cell carcinoma. It was a prospective hospital-based observational study. Study period was 2018 to 2021. In this, 22 biopsy-proven cases of aggressive periocular basal cell carcinoma giving their consent was taken. Histopathologically unproven tumors treated elsewhere and follow-up period less than 6 months were excluded from the study. Detailed workup was done about the location, size, and morphology of the tumor, neck examination for lymph node metastasis, radioimaging for looking at the extension and metastasis, AJCC staging to decide the management and prognosis. It was seen that the male and the female preponderance was almost equal, 50% each. Lower eyelid lateral canthus was observed in 8 patients, that is 36%. Then there was involvement of the medial canthus followed by the upper eyelids and both the eyelids. In morphological form, the ulcerative form was found to be 22%, and morphiform was 22%. The highest morphological type which was seen was nodular and ulceronodular form, which was 27% each. In treatment modalities, 4 cases they underwent exenteration. 12 cases were treated by surgical excision. 6 patients were sent to the oncology department for chemotherapy, and topical imiquimod 5% ointment was also applied in 5% of the patients. And thus, my conclusion is that the management of extensive BCC is challenging, and sometimes ophthalmomiasis can aggravate the condition. Perineural invasion has a very worse prognosis, and early diagnosis and appropriate treatment is mandatory. Multimodal treatment can help in achieving good surgical outcome, and it is also associated with minimal recurrence and extensive basal cell carcinoma of eyelid and periocular area. Thank you.
That was a good presentation, Meghna. I have a question. In which cases have you used this imiquimod?
Imiquimod has been used in periocular tumor which were less than 2 centimeter in size, and it was applied as a 5% ointment 5 days a week for 6 weeks.
So what was the result that you got? Because most of the cases that you are showing are like not less than 2 centimeters,
Yes,
or whatever the
ma'am.
criteria.
It was used only in 2 patients, and it was seen that there were some little resolution of margins. There were size was a little reduced by some few millimeters.
So did you go for the surgery later on? Was that
Yes,
required?
surgery was required because there was no complete resolution.
Okay, one more question is, did you find any difficulties, especially with tumors involving the lateral canthus?
Yes, ma'am. Lateral canthus involvement of the tumors were mostly seen that there was infiltration of the orbit as well, and in 5 patients there was exenteration required when there was lower lid and lateral canthus involvement. Thank you, sir.
Yeah, hi Meghna. So how did you define extensive periocular basal cell carcinoma?
Ma'am, extensive basal cell carcinoma is involvement which is in the periocular area, which is also involving the orbital contents and infiltrating the orbit.
So how did imiquimod have a role in these cases?
Ma'am, it has been seen in the previous studies that imiquimod has proven to be effective when the size of the tumor is small. So I tried applying the cream before doing the further treatment in 1 or 2 patients in which the size of the carcinoma was less than 2 centimeter.
Okay, and what was the overall recurrence rate for all these patients?
Ma'am, the recurrence was a little difficult to follow up as the patients were coming from a background which was very low socioeconomic status, but I followed them for around 1 year, and those who had come, they had very low recurrence rate.
Okay, thank you, Meghna.
Thank you, ma'am.
Next speaker, Dr. Prithvi. He's not there. And then Dr. Dipankar Das.
Good morning, everybody, respected chairpersons and ladies and gentlemen. My topic of poster podium is retinoblastoma and retinal pigment epithelium change. myself and my co-author do not have any financial interest in this oral podium presentation. This is purely an academic one. Well, retinal pigment epithelium is very sensitive layer of the retina, and many drugs, particularly chemotherapy used in systemic therapy of retinoblastoma and other tumor, seems to affect this retinal pigment epithelium in many of the ways. The aim of the study is to analyze retinal pigment epithelium change in post-chemotherapeutic retinoblastoma cases. This was a laboratory-based study from 2016 to 2021. Most of the eyeball were group E retinoblastoma eye enucleated, and eyeballs are sectioned by standard broad left technique. Now these were grossly seen retinal pigment epithelium next day after enucleation in a formalin fixed part of the epithelium was peeled up, and it was flat preparation in the smaller calots of retinoblastoma was stained with fluorescent stain that we have innovated in the raw specimen. They were documented in the objective of compound microscope Axioscope 40 in Axiochem MRC camera compared with hematoxylin eosin stain slide in the permanent section after 3 days. These are the pictures showing the RP changes with the central RP changes compared with the histopathology in the after 3 days of enucleation. Now total 51 cases of retinoblastoma seen, and post-chemotherapy were received eyes was 17 cases. Mean age of enucleation was 4.2 years. Endophytic retinoblastoma was the commonest, followed by exophytic. Choroidal involvement was seen in 47.06% of these 17 cases, and optic nerve involvement was seen in 5 cases. In result, focal and diffuse retinal pigment epithelium change was seen in each case, that is 1 in each case, and central RP change in all 17 cases, both by fluorescein in the gross specimen and HND stain later showed 100%. Drusen's was seen in 8 cases, and RP proliferation was seen in 3 cases, account 17.65%. This is the complete profile of the patient of cases, and here the retinal pigment epithelium change focal was seen in 1, diffuse changes was seen in 1, central retinal pigment epithelium atrophy, which was seen in 17 cases, that is accounting 100%, and Drusen's was seen again in 8 cases, and RP proliferation in 3. For the staining, both fluorescent stain and hematoxin picked up all the cases in there. So whatever our understanding in retinoblastoma pathology is that ERG changes following a chemotherapy already is established, but this study showed the evidence of RP changes all these years, and these were proven by the fluorescent stain and confirmed by hematoxylin eosin stain. Significant association between post-chemotherapy and RP atrophy were seen. To conclude, the study highlights different RP change in post-chemotherapy RB cases which can have significant clinical implication. These are my selected reference. Thank you for patient hearing. I'd like to acknowledge our kids of, with retinoblastoma, Dr. BBCI Cancer Institute, and our pathology lab. Thank you for patient hearing.
Good presentation, Dr. Deepankar. I have a question. How does this, basically, how can you correlate this clinically? Like, what is the significance?
Significant is that, first of all, when you saw it pathologically, now it was, see, whatever HND section we take, we get a single layer of RP or the other things. When you try to see the flat preparation retinoblastoma, when you first saw it, we saw such a changes, the central RP atrophy. Then all these cases were coming, and each of the cases we are examining, and we saw this pathological central RP atrophy. Then when we compared our slide, which showed a significant observation. Now, important thing that apart from this period, all the cases that are coming to the lab, all we are seeing the changes. That is a significant observation. In no cases post chemotherapy we have not found any other change, that central retinal artery. Now, just observe one finding in retinoblastoma survival patient. Most of the kids always use spectacles. What is the genesis? Suppose one eye enucleated, other eye there is a refractive error. Just observe this finding. You find that some sort of refractive error happens in the other eye. Probably this is the RP changes. So, initially before our studies, some ERG studies were made, but it is very difficult to record the ERG in small children. But they have found that some ERG changes happen in the post-chemotherapeutic eyes. Now, this is very significant. Now, whatever CEV chemotherapy we are using for retinoblastoma or added carboplatin, there will be a newer chemotherapy which will be a less side effect in the RP. That should be our goal for retinoblastoma treatment. Because you see, and even not only retinoblastoma, the leukemic cases which has enucleated eye. Now, this has also a change. So some chemotherapy, most of the chemotherapy has a RP changes, and this RP is a very, very sensitive layer, and these get affected by most of the chemotherapy.
Great work, Dr. Das. I had a quick question for you. So, did any of these patients receive intravitreal chemotherapy?
Yes, that's a very interesting question, because some of the cases also received topotecan, melphalan, etc. Now, we have not detailedly compared those studies, but somehow if you put intravitreal or even a conjunctival melphalan or topotecan, they should have some RP changes. But mostly when you put intravenous chemotherapy, it is basically systemic and RP come fast. It is much more change than comparative to vitreous and the subconjunctival local chemotherapy agent.
Yeah, it will be interesting to look into it, because clinically we see a lot of RP atrophy, especially with intravitreal topotecan. So you can look into the differences between intravitreal versus intravenous.
Yeah, and for I have seen few cases of intraarterial chemotherapy eyes. Okay, now these have basically vascular occlusion in the intratumoral zone. That is one difference from intraarterial from the chemotherapy. Here RP changes occur, but intraarterial occlusion happens there much more.
Thank you, Dr.
Thank you so much.
Okay, then we'll conclude this session. Thank you for participating.